Hi guys, and welcome to our second video cast for the Abnormal Psychology unit. Today we're going to be focusing on two different categories of disorders, anxiety and mood. And just to kind of link a little bit back to what we already talked about, right? Anxiety and mood disorders would go on axis 1 of the DSM because they're examples of clinical disorders, right? They are like groups of disorders that other disorders fit underneath. So, anxiety disorders, right? What characterizes anxiety disorders overall are just excessive feelings of apprehension and anxiety. And this isn't like normal everyday worry, right? We all worry. Some of us worry more than others, right? Maybe you got a high or low score on your neuroticism in the ocean, right? In your big five. But for the most part, anxiety disorders are excessive, right? To the point where, of course, right, the 3 Ds. They're deviant, they're dysfunctional, and they're distressful. And we're going to talk about 4 of the main ones and post-traumatic stress disorder as well. So it's generalized anxiety disorder, also known as GAD, phobias, panic disorder, obsessive-compulsive disorder, and PTSD, post-traumatic stress disorder. So, generalized anxiety disorder is exactly like it sounds. It's a disorder where your anxiety is generalized. It's persistent, it's uncontrollable, and it's this tenseness and this worry that something awful is going to happen about any number of things or a whole lot of things, and sometimes you even worry about worrying, right? It's kind of a free-floating anxiety where it's just worrying about everything. And this goes with the autonomic arousal. So, you have your heartbeat, intense heartbeat, breathing, sweat, the kind of things that you would think if in your fight or flight response. And you really don't know what it is that's causing you to feel worry. It's not like something specific. You're not afraid of something specific. It's just an overall worry. A panic disorder, the symptom is a panic attack, right? So a lot of times we think of oh, people have panic attacks, but it's actually you have to have 2 or more panic attacks in a 6-month period to have panic disorder. And a panic attack is just about a minute, maybe 2 minutes of intense fear. You can feel like your chest is like tightening, heartbeat racing, choking, you can't breathe. You kind of feel like this out of body experience, right? It can be very terrifying. And you, like I said, 2 or more in 6 months to have panic disorder. So you can have a singular panic attack and not have panic disorder. And what they find is that sometimes panic disorder in about 1/3 of people can actually cause you to develop this like fear of having a panic attack while alone or outside and not able to get help. And so you develop agoraphobia, which is a specific phobia of the fear of the outdoors or open spaces. So you tend to stay at home and don't want to leave your house. That's not everybody, but some. So you have panic disorder with agoraphobia and panic disorder without. Okay, so phobias, right? Agoraphobia is obviously an example of phobias, but there's lots more. And what's special about a phobia is that it's a completely irrational and persistent fear that disrupts your behavior. I'm afraid of spiders, right? I'm also afraid of these crazy bugs that they find in the city apartments, and we call them peds because it's a combination of a centipede and a spider. They have like spider legs. It's really gross. And I'm terrified of them. But I'm not so terrified that I don't like live my daily life and I don't search for them all around my apartment and I don't run out my house if I see one, right? I mean, I get the vacuum cleaner, I try to suck it up because I don't want to go near it. But still, right? So a phobia is an intense and irrational fear that disrupts your behavior. And if you look, a lot of people are afraid of a lot of things, but a phobia is a different level of fear. It's like the next level. Okay. So some very common phobias: agoraphobia, fear of open spaces; acrophobia, fear of heights; claustrophobia, fear of closed spaces; hemophobia, fear of blood. There's actually a melissophobia. It's a fear of honeybees because the name Melissa means honeybee. All right, next, obsessive-compulsive disorder, right? So this is the big one that you see on TV all the time, and they have all these shows on now, right? Hoarders and all this stuff. And it's persistent, unwanted thoughts. That's the obsessions. And urges to do things over and over and over again. They're called rituals, and that's the compulsions. So you have the thoughts and the behavior, obsessions, compulsions, right? And these cause distress. And they can look like a lot of different things. They can be washing, they can be counting, they can be harming. So some people literally fear like they're always harming or hurting someone. And so the obsession with washing, like the compulsion is washing, right? And the obsession is, oh my God, there's germs and everywhere and whatever. The thought might be, I'm going to hurt someone, and then you have constant checking, right? So you go outside and you look to see if you hit someone. You may count things, like you're worried about the order of stuff. And then hoarding is actually a type of obsessive-compulsive disorder, and where you're so afraid of needing things that the compulsion is, I have to keep everything, I can never lose anything. And what they actually know is that people with obsessive compulsive disorder, their brain looks slightly different, right? The PET scan, right, that's the glucose of their brain, has high metabolic activity in the frontal lobes, which is what's involved in directing your attention. So they're so focused on something and they can't forget about it, right? The attention is there and they can't let it go. All right, and post-traumatic stress disorder. So in order to have PTSD, you have to have 4 more weeks of the following symptoms. Flashbacks, nightmares, social withdrawal, jumpy anxiety, and sleep problems. And a lot of times students can get confused between PTSD and a phobia because sometimes they look similar. Like you might have an accident on the highway and have a phobia of highways, but that's not PTSD, that's a phobia. And PTSD, what I say, one of the main things is those flashbacks and nightmares. So they actually go and relive the experience kind of over and over again. It's very common in rape victims, sexual assault victims, soldiers, children that have gone through war, right? But actually what we find out is that only about 10% of women and 20% of men that are in a traumatic situation actually develop PTSD. And Holocaust survivors and a lot of people that have gone through horrible things actually have really remarkable resilience, right? So, and a lot of, one of the big things that they talk about is that trauma can lead to growth of the individual. So, what causes anxiety disorders in the first place? Freud thinks that it has to do with your unconscious, right? Repressing those painful ideas that you can't deal with, and that gives you anxiety, and then that's what results in a disorder. The learning perspective, right? That's the behavioral, right? That's this one. Learning theorists fear that you or that you believe that you actually condition yourself. So something happens, and then you freak, like something. Like an experience, like something happens bad with a dog, they bite you, right? And then you have this fear, and then you develop, classically conditioned stimulus, unconditioned stimulus. Like we talked a lot about this when we talked about the pickle girl, right? So you actually learn the phobia through an experience. And you can also learn it through observational learning, right? So that's the Bandura social learning, right? Young monkeys develop a fear of snakes when they watch other monkeys who are afraid of snakes. From the biological perspective, we're naturally predisposed to fear some things more than others because they can actually harm us. So there's a little bit of that. Like some phobias are easy to develop than others. And then also twin studies show that genes are partly responsible. Twins are more likely to share phobias. The biological perspective, right, that's our pinky, right? Generalized anxiety, panic attacks, and OCD, all those 3 specifically have brain circuits that have extra activity in the anterior cingulate cortex. And that's a part of the brain that controls direct thinking, and so that the circuits are more active than in other people who don't suffer from those disorders. Okay, next, mood disorders. So anxiety disorders have to do with tension, fear, apprehension, right? And mood disorders are extremes of mood. And generally, we talk about 2 principal forms, major depressive disorder and bipolar disorder. There's others, but those are the 2 major ones. Dysthymic disorder is basically in between being sad and having a major depressive disorder. And it's characterized by daily depression for 2 years or more, but it doesn't have the intensity of the symptoms of a major depressive disorder. It's like mild depression. All right, major depressive disorder, right? Depression is the common cold of psychological disorders because 5.8% of men and 9.5% of women, right? Obviously, we see here women more than men report depression worldwide. So the difference between just being sad is you're sad, you might gasp for air after a hard run, or you might even do that actually if you're Miss Schaefer and you don't work out at all, right? Or major depressive disorder, it's where you have shortness of breath all of the time. Major depressive disorder is not just in the mind, it's also in the body, right? There's body symptoms that go along with this. Right? So that's the symptoms are lethargy and fatigue, so not wanting to do anything, not having any motivation, having a hard time getting out of bed, feelings of worthlessness, loss of things that you used to love to do, loss of things that you care about, friends and family, change in sleeping patterns, change in eating patterns. There can be a lot of different symptoms, and they have to have 2 or more weeks, and they can't be caused by some sort of medical condition. All right. So bipolar disorder then also used to be called manic depressive, and it alternates between the depression I just talked about and mania. So depression, like we said, is gloomy, withdrawn, inability to make decisions, tired, slowness of thoughts, lethargy, all these things. And manic is basically the total opposite of that, right? Elation, euphoria. That means like feel like you're on top of the world, right? You're so excited. You could do anything. You have all of this energy. You're very, even almost hyperactive, right? You're thinking about multiple ideas at once. A lot of times during mania, people don't sleep and they're super creative and they can work and stay focused for a long period of time. And what's hard about bipolar disorder is that a lot of people, when they're manic, they don't ever seek attention. They don't ever seek help because they love being manic, right? Mania can be very scary if it gets to a certain degree, but mania can also be, very productive. You feel on top of the world, right? But when the depressive symptoms come, then they might seek help and they get diagnosed with depression instead of bipolar. And what's bad about that is that depression drugs can actually make bipolar worse, right? So I found this little cute little, it says bipolar bear. You can't see it there, but yeah, so the little cartoon, right? And it's actually a lot of writers, poets, and composers, they actually think have suffered from bipolar disorder because the manic phase can actually give you an intense surge of creativity. Suicide a lot of times comes along with depression and bipolar. Not always, but we connect the two. Each year, about 1 million people commit suicide. There's genetic, so what causes what causes mood disorders? Biological perspective, there's genetics. So it runs in family. It's higher in identical twins than fraternal twins. And there are possible genes and predispositions for depression. There's neurotransmitters in the brain that are involved in this. So people who usually suffer from depression have low norepinephrine and serotonin. And if you have mania, it's actually you have high norepinephrine. And so it's the opposite, right? And you can use drugs to help with this. The brain looks different. So a PET scan you can see here. Look at the depressed brain, how much brain is being used versus the manic brain, right? So there's a ton more energy in the brain and then depressed. Sorry. The cognitive behavioral perspective says that it's more about like the way that you think and the way that you act, and it has to do with the self-defeating beliefs and a negative explanatory style. So it's like there's a cycle of depression. Something negative happens, you explain it poorly, you feel hopeless, and then you figure why bother trying to change it, right? So it's this little circle over here, or like cycle. And so this is the way that it looks, right? So break up with a romantic partner. Someone who has a different explanatory style would say, this is hard to take, but I'll get through it. I miss my partner, but I have friends. It takes two to make a relationship. It wasn't meant to be successful, right? Then where you have someone who is an internal, more negative explanatory style, I'll never get over this. Without my partner, I can't seem to do anything. It's all my fault, internal depression. So two different ways of explaining situations can lead to it. And actually, of course, then we know that it's not just biological or cognitive behavior. It's a combination of all of these things like I keep talking about, bio, psychological, social, right? So it's biological, it's psychological, and it's sociocultural. All right, so that's all for now, AP Psychos. And remember, psychology is flippin' awesome.